Let's have a look at ACE inhibitors. ACE inhibitors can be helpfully identified by their common suffix of "pril". So what is their mechanism of action? How do they actually work? So ACE inhibitors block the action of angiotensin-converting enzyme, which is shortened down to ACE, which prevents the conversion of angiotensin-1 to angiotensin-2. This reduces the production of angiotensin-2, which is a potent vasoconstrictor leading to vasodilation and decreased blood pressure. They also decrease aldosterone production, reducing the sodium and water retention within the body. So why may a patient be prescribed an ACE inhibitor? Or why may you be prescribing an ACE inhibitor? So this patient might have hypertension, which is also known as high blood pressure, heart failure. They may be post-heart attack or post-myocardial infarction as part of the management of that. They might have something called diabetic nephropathy, which is a kidney disease caused by diabetes, and it could also be for the prevention of any future cardiovascular events in high-risk patients. So what are some of the common side effects or common things we need to be looking out for with these patients? So these patients may develop a dry cough, hypotension, so low blood pressure, hyperkalemia, dizziness, fatigue, and headache. Because there's a risk of developing hyperkalemia, it's potentially appropriate to arrange blood tests on a regular basis to make sure that this doesn't occur, or if it does, it's caught early. And in terms of hypertension, monitoring this patient's blood pressure to make sure that they're on an appropriate dose, because obviously this medication can be used to treat hypertension. We don't want them to potentially be on a too high a dose, which is turn their hypertension into hypotension. So some examples include lisinopril, ramipril, cabotril. I apologise, my speech is awful at these meds, and benzapril. So when shouldn't we give an ACE inhibitor? Well, obvious is an allergy or hypersensitivity to an ACE inhibitor. And also, if a patient has had a history of angioedema is a significant side effect that's quite serious, that can be caused by ACE inhibitors. And it causes swelling to the lips, tongue and throat. But specifically if they've had angioedema with ACE inhibitors. So when should we be cautious? Well, if they have some form of renal impairment, bilateral renal artery stenosis, if they've already got hyperkalemia or have suffered with hyperkalemia in the past, and also volume depletion. So these are things that we could give them for it, but we also need to keep monitoring to make sure that it is appropriate with this patient. So let's have a look at a bit more of the sciencey stuff about the pharmacokinetics. So most ACE inhibitors are administered through an oral medication, and the absorption can be affected by food, but varies depending on the specific ACE inhibitor. It is metabolized through the liver and excreted through the kidneys. If you would like to know further information about ACE inhibitors, as well as information to do with specific ACE inhibitors, then please head over to my website. I have a little cheat sheet section under the pharmacological cheat sheets on my store, and there's also 10 questions to test yourself, both multiple choice and short answered questions, and of course the answers are provided. I hope this helps. Let me know if there's any other medication groups you'd like me to cover.